Good afternoon, everyone, and welcome to BNA Live. For all of you all who are joining in BNA Live, the full form is Benjamin Nutrition Academy. It's an NGO which is an initiative of our beloved Salome Benjamin ma'am. Next slide. Uh, the vision of BNA Live is to foster nutrition literacy to dietetic professional, medical fraternity, paramedics, and also caregivers, both in the field of specialized nutrition, enteral and parenteral. Next slide. Uh, Again, your the mission was to kind of get everybody on the same platform and to enable young medical doctors to understand the application basis medical nutrition therapy, to educate and empower patients and caregivers and our very own dietitians across to kind of help them update and decode nutrition in a better way. Next slide. We all know Salome Benjamin. She's the founder of the Benjamin Nutrition Life Society Academy, and ma'am has been a very renowned personality with over 45 years of experience. She has been a consultant medical nutritionist at Jupiter Hospital. Before that, she's had a stalwart career at TN Medical College and BYL Nair Hospital. She is an author to several books. She's been on various national and international studies and has been a regular speaker and chair at many of the national and international conferences. So, thank you, ma'am, for giving us all the opportunity for hosting this show today. Next slide. We have our very dear Dr. Eileen Canday, who is the head of Department of Nutrition and Dietetics at Sir H.N. Reliance Foundation. She's a very valued RD board member of the Indian Dietetic Association. Eileen is also the secretary of IAPN Mumbai chapter, and she's the chief officer for the IAPN Transplant Co Group. And Eileen has been is on several study boards of colleges. She is a certified IBS trainer from the Monash University and has completed several levels of the Aspen courses. She's had several awards and has had many publications to her credit. And she's also the founder of the Academy of Nutrition Sciences. Eileen, welcome. It's a pleasure to have you today. Next slide. Uh, we have Dr. Pankaj Shah, and we learned that Sir is joining actually from his vacation, and we are truly indebted for that. Sir is an MD, DPH, and a AFIH. He is an MBBS from Government Medical College, Meerut. He's an MD from Tata Memorial Hospital. He has been in private practice since 1987. Currently, he is the managing director and CEO of Aspira Pathlabs and Diagnostics Center. Um, Aspira is an NABL accredited lab and has several facilities across Mumbai, and it does amazing work, including lab management. It has several branches in Surat, Nasik, and we are indeed very happy to have you, sir, because it is a very different topic for us. This is the first time we are actually deep diving into a topic like this, and
Yeah.
over to you for your session. Thank you.
Thank you very much, Nazneen. Indeed, a wonderful introduction. And it means a lot when we have experts from other area joining us. Sir, the audience here is mostly dietitians, clinical dietitians, and uh, since today nutrition science has taken a big leaps, we thought this kind of sessions would help them to understand, to use the lab reports in a better way. But when we started looking at it, deep diving it, each report is a report by itself and it can take hours together to talk and decipher about it. So we thought we will take only one area of that report and talk about it. And hence today, it's more of a panel discussion, case-based discussion, your experience, your expertise, and Eileen Candy's expertise. Plus, we have other panelists here who are eminent nutritionists. One of them is Nazanin, who just spoke, and our own mentor, Salome Benjamin, ma'am. All of us will be talking and decoding the science of how a lab report needs to be read and what needs to be interpreted out of it. So let's start with the panel discussion. My first question, because it's a dietitian's group, Dr. Eileen Candy, with a vast 25, 30 years of experience of yours, Eileen, you've been into a clinical practice, seeing patients into the hospital practice. I want to understand, and I want you to tell the dietitian audience here or the audience here, why is it crucial for dietitian to understand pathology reports? Because dietitians mainly do weight loss and some kind of cosmetic nutrition. So it is really important that they look at the lab reports, and especially the chronic conditions like commonly metabolic syndrome and all. How do you generally work with these kind of reports in your clinical practice?
Thank you, Geeta, and thank you, Nazneen, for that kind introduction. Geeta, what you aptly asked is, as a dietitian, is required, do we require to actually look at the reports? Now, frankly, it becomes very difficult for me to give an counseling or an advice to somebody without looking at them internally. And by internally, I mean is that I follow the NCP process. The NCP process is very simple. We have all learned that you have to do the ABCD method of assessment. And when we do the ABCD method, we are very pro in doing anthropometry. We are very pro in doing nutritional assessments. We may also do our clinical and our dietary aspects well. But the A is for anthropometry, B is for biochemical, C is for clinical, and D is for dietary. When it comes to the ACD, we are all experts. When it comes to the B, I think that is something which is very important for us to. That B is where the biochemistry of the patient is important, because it gives us an essential insight into the patient's health condition. Whether it is metabolic disorders, whether the patient has infection, or the patient has got a deficiency, organ failure, abnormalities, we look at it from that point of view. Also, there are certain aspects like the inflammatory markers, where we now also look at C-reactive proteins. We look at the blood glucose level. We look at the lipid profile. All these things come from nothing but from the biochemical markers, which we cannot just by looking or doing any other assessment come to know the nutritional status of that patient. So hence, as a dietitian, I do look at the reports, and the importance is for me to interpret them correctly to give the right advice.
Fantastic. So after A, anthropometry, B is a very important area where each one of us in our practice have to go through it, and it helps. Dr. Shah, thank you for joining, and our apologies to creep into your holidays and ask your 1 hour of time here, but we really are happy that you're with us, and your CV says so much about your experience, sir. Yeah. Have you any time thought about how a pathological report will help for the nutritionist to decode the health? I mean, what is your input? Like Dr. Eileen was trying to tell us that she does, as a dietitian, look into pathology. But according to you, in your thought process, and how a nutritionist should look at pathology report, and then we start decoding the CBC report. Over to you, sir.
Thanks, Geeta and Nazneen, for a nice introduction. Whether vacation or if I'm working, this dietitian's point of view, nutrition and pathology interpretation is my interest of topic.
Wonderful.
I really enjoy doing that because I'm doing so since so many years. See, nowadays with newer approach, dietitian's role is not just weight gain and weight loss treatment. Now if you see, there are specific line of patients, they come like now. See, with the longevity of the life, most of the people are crossing around 70 years. So there the dietitian role comes, with what type of food to give, what, and what is the outcome. Yeah.
So you continue, sir.
And even in cancer therapy, dietitian's role is major because then what diet to give and everything you have to decide depending on the biochemistry. So biochemistry and treatment of dietitian advice would be first you have to look at the uh, vital parameters like what we have a metabolic profile. So in that you know that kidney function, liver function, and then like thyroid function is so important. Whatever for weight loss, whatever patient comes and if she is hypothyroid, unless hypothyroidism, whatever your dietary advice you give, she is not going to he or she is not going to lose weight. So you have to look at at all the parameters. I am going beyond this. There are so many food allergies to patients, and so what we have for allergy, we have IgE mediated and IgG mediated. So IgG mediated is food intolerance. So I have couple of patients who were advised dietitian by a dietitian to for weight loss. Certain food were advised after interpretation of the biochemistry chemistry, and we found that she was intolerant to so many food. So that was also interfering with her, not losing weight. So now the scenario has changed. So you have to have multiple approach.
This is interesting to know, sir, that dietitians are understanding the importance of pathological test, and they are also referring patients apart from clinicians to understand the blood values better. And things like food sensitivity is gathering so much of attention, and weight management also is impacted if
Yes.
you understand your food sensitivity. Now, we will come back to the today's topic of major discussion, and I'm sharing my screen if you can see it. Nazneen, can you see the screen?
Yes.
Yeah.
Yes.
Yes. So, because as you rightly said, once we will also have you for food allergy discussions. That's a vast topic of interest, and we would really like to understand IgE, IgA because we are very much dealing with it. But today, I thought only one paper which we want to highlight today is complete blood count report. Well, first question to you, sir. You can see the report which have been displayed, and this is not a new thing for you, but for my friend audience who've joined, we want to decode this report because generally what happens, sir, we only check hemoglobin in this report and we don't look at any other parameters. And we want to understand it much better. So,
For
sir,
that,
yeah.
can you touch your window, please? On the right hand
Oh,
top.
yes. Sorry, sir.
Yeah.
I think I'm trying to see both. Okay. Yeah. So, is it clear?
Yes.
Yes.
Yeah. So, sir, my first question to you, sir, this is a CBC report. According to you, as a pathology expert and nutritionist who actually looks at food science, food physiology, and integrate her thought process of what foods to be given. So, in this CBC report, what should be the dietitian's area of interest? What should she be looking at? One is hemoglobin, definitely. Apart from that, there's so many parameters here. And what do you feel she should be looking on those parameters?
See, first you have to look at the RBC count and hemoglobin.
Okay,
Obviously, here obvious RBC count is low, hemoglobin is low, pack cell volume, that is hematocrit, is low. So definitely patient has anemia. Now anemia interpretation would be to see MCV.
okay.
The MCV, if it is elevated more than 100, it
Yeah,
is, unless proved otherwise, it is a vitamin B12 deficiency, folic acid vitamin B12 deficiency.
so can you repeat this again, sir? The MCV value?
MCV more than 101,
Okay,
uh, it is, unless proved otherwise, either vitamin B12 deficiency or folic acid deficiency.
interesting.
Okay. Now, if you want to confirm whether it is really megaloblastic anemia, vitamin B12 deficiency, megaloblastic anemia, you have to do one more test, that is LDH. So LDH is elevated before doing bone marrow. Sometimes bone marrow is also advised. And if MCV is less than say 80, it is a microcytic anemia, so it is a iron deficiency anemia. Along with these parameters, you have to also see RDW. Suppose MCV is low and RDW, if these two parameters are counted, and you can diagnose also even thalassemia. So thalassemia is diagnosed on three things. One is Menzer's index. It's a calculated parameter. There are some counters which gives quantitative microcytes. Suppose in this case 2.98 millions are RBCs. Out of 2.98 RBCs, 50% are microcytes and 40% are hypo. So this is definitely a microcytic hypochromic iron deficiency anemia. So if you do M by H ratio, if it is more than 1, it is 99% thal minor. So there are three parameters on which you can suspect thalassemia. One is on Menzer's index, RDW and MCV, M by H ratio. Of course, you have to confirm that with HB electrophoresis by HPLC method. Then only you can say it is a thal. So thalassemia, you don't have to treat with iron or anything because iron will be overloaded, So you have to just give folic acid. And hemoglobin, you can tell patient hemoglobin is not going to increase more than 10 or 11. But you can maintain it with white.
So according to you, sir, hemoglobin is 8.4 here. MCV
Yes.
is normal, MCH is normal. What category does this?
So this will require smear evaluation. Sometimes there is a dimorphic anemia, microcytic hypochromic and macrocytic hypochromic. So you get mixed by iron deficiency and a B12 deficiency. So this you have to interpret slide properly. From slide review, you can tell what is to be interpreted.
Interesting. What a great insight, sir. I don't think we think that way, the way you had mentioned now. And going forward, we'll definitely start looking at this and read more about it as we are trying to understand this. Dr. Eileen, as very beautifully, sir, tried to tell us what kind of microcytic, macrocytic, B12, thal minor. So, can we have the audio on mute? Sheetal? Yeah, thank you. So, Dr. Eileen, I wanted to understand what are the parameters as a nutrition expert you will look into it. Now that we've come to know what we should be looking into it, but in your regular practice, how do you interpret this CBC report?
Okay. Dr. Pankaj will elaborated the importance of the SPC or the RDW. However, when we are looking at it from a dietitian's point of view, there are some inferences that we make because we want to give a nutritional advice to the patient. So the first thing that we will look is in the CBC is the hemoglobin, or we will understand the Sheetal, can you mute yourself, please, Sheetal?
Otherwise, I think we can at the back end mute all audience.
Yeah.
Yeah. So thank you. So we look at the hemoglobin and the hematocrit, and these measures are definitely the indicator of the red blood cell volume, as well as we know that it is the oxygen carrying capacity. So as Dr. Pankaj rightly pointed out, that it also could mean that the patient could be anemic either due to iron deficiency, either due to a B12 deficiency, or due to a folic acid deficiency. Now, when we look at it from the nutrition point of view, and we have, as I said, that we have the ABCD method, and in the D, we have looked at the dietary. And in dietary, we have realized that this patient is a vegetarian patient. He's not or she's not eating any sources of B12. There is a high possibility that there could be a B12 deficiency. Also, once we take the dietary history, we realize that maybe folic acid rich foods are not present, or iron rich foods are not present, or we may find that, okay, this person is having a regular cup of tea after the lunch in the office, so there could be an iron deficiency. So these are when we correlate the CBC with the dietary, we realize that there is something correlation which does not allow for the hemoglobin to increase. It could be any of these conditions. Now, based on this, we also look at the RBCs. So when we know that the RBCs are low, it can indicate that there is any of these, either anemia, nutritional deficiency. Sometimes we also see the WBCs or the platelet counts. Now, these could mean different other things. I'm sure Dr. Pankaj will have his interpretations for this. But as a dietitian, we look at our immune system, we look at immune health, we look at infection, we look at inflammation. Also, we look at platelet counts. So all these things make a difference in our interpretation where diet is concerned. Uh, if there is anything else, maybe Dr. Shah could also add to what I said.
Yeah, so you rightly said, just only hemoglobin and all other parameters. You have to see total count also, platelet count also. You have to see in toto CBC what are the other parameters. When sometimes the counts are high and other all parameters are normal, so there is definitely some source of infection in patient. Like some of the pathologies, they report atypical lymphocytes also. So atypical lymphocytes typically you get in viral conditions. So in viral conditions, patients, they lose appetite. So that also impact on health. And
Correct.
you rightly said, poor nutrition and inflammatory disorders are interconnected. If you have poor nutrition, your inflammatory disorder will be worsened.
So, sir, according to you in this report, what kind of anemia are we looking? The three types of anemia which we need to understand, where we can play a role. Thalamide, we cannot. So, in this report, the hemoglobin is 8.4, and you said it is further evaluation. But if you look at the MCV, MCH is normal, but otherwise RDW, TLC, neutrophils, they
Yeah,
are all not in a normal range. So would you
yeah.
think that they need
So
further evaluation, B12 checking, or any other things need to be checked from this?
yeah, so see, TLC is high, 14,610 is total leukocyte,
Yes.
and neutrophils are 90%. So
Correct.
this is definitely acute bacterial infection.
Okay.
So you have to confirm with other inflammatory markers like CRP and ESR. Of course, is not that specific now. CRP is a better indicator, and along with CRP, procalcitonin. PCT, what we call it PCT. So procalcitonin will give. Of course, procalcitonin only clinician can decide whether to do or no, because procalcitonin is elevated in septicemia. Whenever there is severe sepsis, you get procalcitonin elevated. So this
Interesting.
case is definitely acute inflammation and acute bacterial. See
So do you feel that
why
might be,
bacterial? Because neutrophilia. Because of
yeah,
neutrophilia, I am labeling this as a bacterial.
yeah. So do you feel is that giving a reason for anemia, or it is nutrition? We need to still do further evaluations to
No, we
understand
have
what.
we have to further evaluate this patient. This is not the direct cause of anemia.
Interesting. We have Dr. Salome ma'am here also. Ma'am, would you like to ask you a question to both of the panelists? Or anything you would like to highlight to this report, what we discussed now?
Ma'am, you're on mute.
Ma'am, you're on mute.
Sorry. So thank you, Dr. Shah, and welcome you today on our
Thank you.
board today. And Eileen, we always have her, and I'm very grateful for both of you to join. So thank you for this great insight given to us, because sometimes we miss out on relating these parameters one to another.
Mhm.
And if I have to know, I'm still, I can say that every report makes us learn something new. So when you said relate RDW with your MCH and NCH, uh, apart from that, thalassemia or a different anemia, any other thing with abnormal RDW do we have to look into, Dr. Shah?
No, really not. All this hemoglobin, RBC count, REW, and this indices. Indices consist of PCV, MCV,
Yeah.
those indices. Their
Okay.
role is only for diagnosing anemias.
Okay, so
Okay.
RDW is
So
important only for anemia.
yeah, so sometimes we have polycythemia vera also, whereby PCT is elevated
Yeah,
to 60, 70. RBC count is also increased.
yes, yes.
So all these parameters of indices are only related to RBCs,
Okay,
RBC diseases, not otherwise.
okay. So we need not dive deep into it that why the RDW is abnormal and do any more
You
investigation.
you you have to talk to pathologist.
Okay,
If suppose patients are coming with to you with chronic anemia and
yeah.
RDW elevated, MCV elevated.
Hmm.
I mean MCV low and RDW elevated. So
Yes.
first you have to talk to him whether are you sure this is iron deficient? Can you differentiate between iron deficiency anemia and thalassemia?
Okay.
So if he says this is definitely iron deficiency, you treat iron with, of course, and if it is thalassemia, you don't have to treat exactly. Only thing is diet you can give proper because thalassemia, if you give more iron orally, what I mean to say is more preparation. More tablets and all those injectables.
Yeah.
It will harm patient. It will not help patient. And
Exactly. Exactly.
hemoglobin also will not increase. So I have seen so many times, hemoglobin low, and in a thalassememic patient, not knowing that this patient is thalassememic, people they
Yes.
give iron, and they land up with iron overload in reticular endothelial system.
Yeah. We
That is more
understand.
worsening. So then they have
Minor
to,
thalassemia. Yeah. We
yeah.
miss out.
So then they have to take chelating therapy. Iron they
Yes.
have to chelate, which is more serious than treating. Uh,
Anemia or
So only
thalassemia.
only
Yes.
dietitian point of view, I think if your MCV is low and RDW if on those parameter and just if your organization has facility of microcytic and hypochromic quantitative, just
Hmm.
do M by H ratio. If it is more than one, it
Okay.
is it is it is it is to be proved that this is thalassemia with HB electrophoresis.
Okay. Thank you so much. Because many
And
times
moment patient is thalassemic, also that his or her family members also should be
they
screened.
will know. Yeah, they will. Sometimes they know, and sometimes what happens is the patient comes to the nutritionist or a dietitian first before going to any doctor. So there is no clinical impression or the diagnosis written there that
Right.
this patient is so much. So we are the first one to interpret the biochemical data. So
Yes.
as Eileen rightly said that it is important. So as a nutritionist in my practice, I do have my nutrition diagnosis based on the biochemical parameter. So
Right.
we, apart from the clinical diagnosis, we do write our nutritional diagnosis, and because we are the one therapist treat this nutritional diagnosis on the whole. So that is why I wanted to know these parameters in this detail from you.
Yes.
Thank you so much for showing the light on that.
Thank
Uh,
you.
we can move forward, Geeta.
Yeah. So, Dr. Shah, Dr. Eileen, now what we interpret is what you've told us, sir. So,
Hmm.
according to you, when should the dietitian feel alert? Where is her role? A nutritional anemia, inflammation, or rule out thal minor, or normo macro or
Hmm.
micro anemia? How will she try to make her nutrition diagnosis? Especially if you look at this report, hemoglobin is very low, so the dates and all the food therapy will start coming in. Patient will start eating pomegranate. But end of the day, as per you as a pathologist, how will you interpret this report? What immediate therapy? Hematologist, nutritional anemia, physician, supplementation? We would like to know that what is the roadmap for this patient now?
For for this patient, roadmap would be, since it is an acute infection, first you have to treat the infection.
Well,
Yeah, because count is high, neutrophilia. First, you diagnose where is the infection source of infection, whether it is a pneumonia or there is an abscess in the body, pneumonitis. You have to first diagnose what is the source of infection and treat that source. Moment your source is, if it is treated with proper antibiotic and then repeat CBC, if counts are coming down, that means infection part is taken over. Then you can concentrate on indices. It might happen that indices might, with the infection, indices might, hemoglobin might improve and indices might be affected. So that time you can interpret what to do further.
Great. Sir, if inflammation was not there, then how would you look at this report, sir?
If inflammation is not there, then I will see the smear whether it is a dimorphic anemia, micro macro mix.
Okay.
So you have to treat with both.
So how
And if
do we
it,
look at it, sir? We can't go to pathologist every time. So what are the indices I should depend my interpretation on?
no, micro, see, in every pathologist report in that morphology of RBCs.
Correct.
Mm.
So in morphology, if they have reported micro 1 plus macro 1 plus and hypo 2 plus,
Yeah,
so that means it is a dimorphic anemia.
correct. So I think we don't have in this report, but yes, you rightly said that, sir. Okay, Dr. Eileen, over to you now. Now that we know inflammation, hemoglobin, I didn't look at inflammation till Dr. Shah mentioned it to us. I was only looking at 8.4, and I was thinking that how do I address this? Now I treat the inflammation or I treat the anemia. How as a nutritionist will you interpret this report?
Okay, so definitely we know that there is an anemia related here in this, and we need to give foods that will correct the anemia. And as we looked at the MCV as well as the RDW as well as the MCH, we realized that probably we also need, and we correlated to the diet, the dietary aspect. We need to give foods that are rich in not only iron but B12 as well as folic acid. Sometimes some patients also need an adequate protein diet. Since we know that hemoglobin is a combination of heme and globin, so the heme part of it, which comes from the iron, that we can give from the foods, that is not only iron rich foods but also other foods that make iron, that make the hemoglobin. So the protein rich foods as well as the foods that are good in iron. The other thing is we also need to look at B12. Now we understand that we can give B12 to a limited extent, okay, from the diet, because some diets cannot be high in B12 because they are vegetarian. For these people, sometimes we need to give a supplement where B12 and folic acid is concerned. However, from the diet, if a person is a non-vegetarian and is eating like meats, poultry, fish, eggs, that can be given. Some of the cereals or some foods also have fortified B12, which may be plant sources, but the foods are fortified with B12. That also can be added, like some of the nutritional yeast, which have got, which is a good source of B12. That can be also provided to the patient. Coming to folic acid, usually when we are providing a nutrition education, especially to pregnant women, we know that they are taking folic acid supplements. We also need to give foods and foods that are rich in folic acid, whether it is green leafy vegetables, sprouted legumes, whole grains, citrus fruits, because we know that iron also requires vitamin C or a citric environment for its absorption. So when people come to me and tell me, oh, I'm eating beetroot, or I'm eating pomegranate, or I'm eating these foods or I'm eating an apple because I want my hemoglobin to increase, I don't stop them from eating it. I just educate them. So I tell them that these foods that you eat, when it comes to you know eating beetroot or apple or pomegranate or other foods that they feel that has got iron rich in it, it actually has other food substances that help in the absorption of iron. So it may be vitamin C rich, which helps in the absorption of iron. So this is what I inform them. Also, I look at the kind and quality of proteins that they are taking. So that is also very important, because when we want to form the hemoglobin and when we look at their reports, maybe if you go further on and see this patient's reports, and if he has got a bacterial infection, or if he has lost his appetite since many days, he may not be having adequate proteins also in his diet, which in turn also affect his hemoglobin status. So those things need to be taken care of.
Yes, Dr. Shah.
Yeah, see, Eileen rightly said. Uh, uh, I think grossly, I would divide all this nutritional aspect in two ways. One is approach should be two. One is disease oriented and wellness oriented. Wellness, what do you mean by wellness? There are some wellness profile you have to do, which includes this metabolic profile also. So moment those are normal, then you can treat patient properly. I have seen my own experience. Just a couple of months back, one young fellow, 28 years guy, came to me for certain test, and his creatine was very high. So I just, because he's looking at his physique and all, I said, "Are you doing gymming?" So he said, "Yes, I'm gymming freak, and I'm very health conscious. I eat this, I eat this, I take this much of protein every day." So that protein had created issue for him. He went into renal failure, excess of protein. So you have to really, before treating patient, whether you are that patient is for wellness program, that means weight gain, weight loss program, or disease. So this first thing, I think we will have to segregate these two things, and you can treat that way. So metabolic profile you have to do. So as I earlier also said about TSH. So TSH, if it is elevated, so you will come to know from blood report only what is the status of all these things. Like uric acid elevated, and if you give excessive protein, you are worsening that patient.
Geeta, today morning I had a patient who came to me in the OPD, CKD patient, and this patient's hemoglobin was very poor. And she came to me just to increase hemoglobin and iron. And then I just went through her reports, and I saw that I asked her first, "Are you taking erythropoietin injections?" So she wasn't sure of that. She said, "Yeah, I'm taking insulin and I'm taking something else." And then I had to explain to her actually that in such cases, when she is CKD, her hemoglobin is low because of the lack of erythropoietin. And therefore, when I looked at her medications, I also saw that yes, she has erythropoietin injections, and which she's saying I have to take those medications. So that is something that we have to realize, that when we are looking at anemia, it is not only because of iron, folic acid, or B12. It is also because of other disease conditions. And in a disease conditions where the kidney has been affected, only then we have to look at the other aspects of it. So when Dr. Shah did say that patient may be already having a kidney issue and then he has abused his kidney, that's where he would have a creatinine problem. But somebody who does not have that problem, and we are unnecessarily cutting down or restricting diet for those people, so that that decision is a very critical decision which a dietitian has to take.
Absolutely. Yes, Dr. Shah. Sir, you had to say something.
See, we couple of times we mentioned about CRP, which is the inflammatory markers. I think as a dietitian, you should order CRP for each and every patient,
Yes.
because chronic inflammation can impair nutrient absorption. So whatever nutrient you give, it's not going to help patient.
Agreed.
So there also you have to find out, then dig down, and what is the what is the chronic inflammation source. Treat that with the help of clinician. So malnutrition, is a big challenge for all of us.
Very true. So taking little away from the first part of report to the second part of report, you did help us understand that this is high inflammation and all. But in fever patients, like in dengue or anything, we have a lot to do with platelet count, eosinophils. Do you feel nutrition, except for inflammation, CRP, which you did mention? Because it's only not the CBC now. Now we are taking the CBC to various areas, the kidney failure, the other areas of hemoglobin aspect, and etc. It's not only CBC. But in this report, I wanted you to tell us that how does a nutrition look at this part of the report, apart from infection, any thrombocytopenia or anything where she can interpret, and then I'll forward the question to Eileen, that how would she look at the nutrition aspect of it? Over to you, sir.
See, thrombocytosis, there is not it's not going to create any problem. Of course, you have to find out why there is a thrombocytosis. For that, you do bone marrow and confirm whether what are the megakaryocytes and what is the turnover of the bone marrow. For thrombocytopenia, first you have to rule out, whether it is due to infection or non-infection. So, idiopathic thrombocytopenic purpura, it is uh, there are two things. It is idiopathic, so nobody cause, nobody knows. And second cause is drug induced. There are so many painkillers and all those things that can suppress bone marrow, and then platelets are reduced. Now, in inflammatory condition, there are some certain viral conditions whereby in viral infection you get thrombocytopenia, including dengue. Dengue is a viral, infection. So in that there is definitely, thrombocytopenia. So those patients, they have to have good healthy food. See, dengue, if you see, what are why patients have complications of dengue? Because there is a hemo concentration. If you see their hemoglobin will be more than 16, 17. So there is a hemo concentration. So hemo concentration can create issue, and then patient they have lung involvement and then complications. That there is a lot of other complications, in the sense there is uh, ascites and pleural fluid effusion and multi-organ failure. So first, if platelet count is low, and if some patient comes to you that my platelet is low and I have a dengue, and give me some food for to increase platelet. So nowadays, there are so many people, they come to me with this papaya pan and papaya preparation. But honestly, I have not done any research on that, whether really it is due to those supplements platelets have increased or no. There is no proof. I mean, so, and I also don't believe that it's a natural process. Moment your hemo concentration goes down, your platelet count starts increasing. And platelet less than 20,000, you have to admit patient and give platelet transfusion. Now, in that also there are neuroparameters which has come, which is IPF, immature platelet fragmentation. So suppose platelet count is 50,000 and immature platelet fragmentation is 11%. I am sure this patient is going to come to, will recover his platelet within 48 hours. So I give assurance to that patient, come to me every day for CBC. Don't worry about your platelet dropping, but I want to see your IPF. If IPF is increasing, I am not worried. You need not do platelet transfusion. You need not do anything else. But of course, with the help of clinician, I don't take this decision, but I take clinician in confidence, and I tell them, I am doing daily this platelet, and if IPF is not increasing, he will come to you immediately.
Rightly said, sir. Uh, when the patients, you understand the patient's IPF, and then you give that prediction. Now, in this period, if the patient has taken the papaya leaf juice and taken everything else, the dragon fruits
We
and
don't,
everything,
yeah,
anyways, his platelet will increase. So
yeah.
it is.
So
It doesn't matter whether whether they have taken it, and because of that they have increased. And if the IPF is anywhere good, that means that
yes.
it is going to increase. And in that period, if somebody advises them, okay, now you take this juice and take that fruit and all
So
those things, you can also.
all credit. That's how alternate medicines and alternate people are thriving on.
Yes, yes, yes,
So what time patient goes to them is very important.
absolutely correct, and
We
I fully agree with you. It is what
to
time.
how month is following day to day, there will be now hepatitis A. We have we know that that virus is going to 4 to 6 weeks. The patient will recover, but then then they go to pathologist or clinician on second week. The second week, third week is a peak. That illness increases on third week. Third week, somebody advises, typically neighbor and friends, and somebody to he does good, gives some powder, and he does some jaundice will go. Anyway, from 4 days it was going down.
I agree, sir. Patients get admitted in the initial phases here, in
Yes.
our hospital. And they all ask me food pass, because we don't give in our hospital all those different juices.
Yeah.
So they ask me for food pass to get these, extracts and juices from home. And, of course, we do not allow that. And nevertheless, they really insist that they want to eat a dragon fruit, and they want to eat kiwis, and they want to eat all those leaves and all those things. See, I don't disagree that those foods are not anti-inflammatory, which they want to eat, so I don't have a problem them eating those fruits. So I give them anti-inflammatory fruit. I will give them a red,
Give the credit to platelet and that fruit.
correct, I will give them a red dragon fruit if they like to eat it. Okay, but equally I will give them other inflammatory foods also. I will give them I will give them an omega-3 rich food also. I will add garlic, I will add turmeric to their food. So I will make their food anti-inflammatory rich anyways. Okay. And because of which they definitely, their platelets will, it will eventually increase. They will feel good about it. Their immunity gets stronger. So it all is a coincidence sometimes. And we have to realize that it is the food that also helps them to fight the inflammation. But it is not a particular food only that will help you fight that infection. It is a cumulative of all the anti-inflammatory foods that you are giving for that person at the time of infection, whether they are having a thrombocytopenia, which is low platelet, or they are having thrombocytosis, which is high platelets. In both those conditions, you need to give anti-inflammatory foods to your patients.
So inflammatory diet also consists of some of the antioxidant. So that also helps.
Yes.
Interesting. So wonderful. I think this closes the CBC and we will move to other. But now to infer from all the expert inputs, what I would like to highlight and take it forward for dietitian friends, just don't look at hemoglobin. There's so much else to understand from this report. Then Dr. Shah very well said that nutritionists have a role to play. If you feel any plus minus in this report, we need to divert the patient to the expert, because it is you, like Dr. Salomi ma'am said, it is you who will actually understand what is the next point of contact for the patient. Don't leave the patient here by giving an iron-rich diet. It is to work on inflammation. It is to work on your other areas. Of course, nutrition, balanced diet is the way forward. And of course, for this patient, is an anti-inflammatory diet. So I think a point very well taken by the panelists. And now we also have some questions and all to take. But before I take questions, my last question to both of you, and then we move to the audience question answers, is this is the first time where I thought pathologists, we always go to physician, we go to the expert doctor, treating doctor for any kind of patient related queries. And this is the first time I am looking at a pathologist expert inputs here. So do you feel the dietitians should call up a pathologist and understand the report whenever needed? If the report is somewhere they feel like today's report, we forgot the inflammation part, we forgot the thrombocytopenia part. So do you feel a nutritionist should call up a pathologist, or they should call up the treating doctor? How is the road ahead for us to coordinate with the clinician?
Both are important. See, if you're taking health, you're treating disease patient.
So your voice is breaking a bit. I'm sure everybody feels the same. Can you repeat that again, sir?
See, both. See, if nutrition is treating patient disease, then he or she has to contact pathologist and clinician both. Then understand disease and under by pathologist. If it is a wellness program, see, we have a lot of preventive checkups now. Every hospital preventive checkups. I also have a lot of preventive checkups. So if patients of
Sir, your voice is breaking. I think you can put the video off, then it will be more clear.
You can do that, so you can put up the video.
Yeah.
Yes.
One moment. I'll go out.
It's better, sir.
I'll go on terrace.
So in the meanwhile, I'll just talk about it. So
yeah. Is it? I'm audible. Am I audible now?
Yes, audible.
Yes, sir. Please go ahead.
So, if you are treating patients with wellness program, then you may be in touch with pathologist only, because this is a normal patient who has come for wellness program, and we have done certain battery of investigation, and that includes all metabolic tests also. Okay.
Noted, sir. I repeat, you said if it's a wellness program, patient comes some kind of a wellness report, he gets in touch with pathologist. If in case of illness, with treating physician, and then
Yes.
if needed, go to a pathologist. I think
Yes.
this is what you tried to mention.
Exactly.
I will over to you for your comments, and then we take the questions. Yes.
So, Geeta, what I do is that I sometimes I need to coordinate with both, or sometimes with only the pathologist or only with the physician, based on what is the individual variability and the communication I want to give to the patient. If I have to give some communication to the patient from my side, I need to be doubly sure that I am not communicating something wrong to the patient. Okay, it could be sometime a false negative, a false positive, it could be anything, which I need to understand that, if I'm doing a comparative test between the last test and this test, and if I feel there is something which I don't understand, I think it's best to clear it out with the pathologist, because he will be able to interpret it in a very different manner than what you can interpret with your limited knowledge. Where it comes to explaining to the patient about the disease condition, if it has been established well pathologically, that's when I will connect with the doctor or the physician and ask him his opinion, and then kind of integrate both the opinions before I give counseling to the patient. Because when I give counseling, I need to give a nutrition counseling, but to give a nutrition counseling, in my head I need to be clear of what is the actual condition of the patient, rather than giving any false information to the patient. So I think communication with the patient, individual variability, and integrating the any ongoing wellness program or a disease support program with the patient is very important at that time.
Makes a lot of sense. So coordinating is the key forward for us to communicate effectively, because point of communication, counseling, is the dietitian. So we cannot go away from our ethics by declaring anything which we are not sure about. So I think point well taken, Dr. Eileen. So a few questions. We have only 5-10 minutes more to go, and then we have expert input from Dr. Saloni ma'am also. Is RDW, Sandhya asks, is RDW also an inflammatory marker? Can we look RDW as inflammatory marker?
No, it's not an inflammatory marker.
Not an inflammatory.
No, it is related to RBCs only.
RBC, fantastic. Sometimes
It's a red distribution.
It is the width of the red cells.
Width of the red cell which are related in a histogram.
noted.
Yes.
So sometimes we only find high creatinine, but all the RFTs are normal. What is the reason, and how do we take the patient from there going ahead?
See, only creatine may be high if it is, there are for increased reasons: pre-renal conditions, renal conditions, and post-renal conditions. So pre-renal is called dehydration.
Dehydration.
So dehydration, first level to increase is creatine parameters will be, and history will be very short. Only and its leading history. I have died since 4 days. Copious diarrhea. I have vomiting also. I cannot eat also. So those are the pre-renal causes.
Noted.
Renal cause, of course, acute renal shutdown. So this dehydration, there is acute renal shutdown.
Okay. So you can put off your video also, sir. I think there's still break in your voice, so that will make it more clear. Thank you, sir. So another question, is it always CRP or HSCRP? Both.
See, HSCRP, if it is HSCRP is more of a inflammatory marker. Inflammatory in the sense related to coronary.
Okay.
Coronary.
Yes.
Or vascular health.
Vascular, yes.
Noted. And CRP is a normal inflammatory marker which we will
Normal. You must have seen in COVID, we did so many CRPs for so many days. People were treated. The infectivity or severity was judged by CRP and IL-6, and there's some other parameters.
Yeah, makes sense.
Yes.
So what is a common
So
cause of
moment in COVID, day 3 CRP was reducing. Clinicians were sure that this patient will recover.
Correct. So CRP was a marker for us to understand the viral infection load also.
Yes.
So what is a common cause of eosinophilia? And Bhumika is asking, she has a client who feels Whenever his eosinophil counts go beyond normal, the patient is always in cough and I think more of wheezing and all starts. So what is the cause of
Yes.
eosinophil? Is it trigger, infection, inflammation?
So eosinophilia is a condition. There are two conditions in that. One is tropical eosinophilia, and eosinophilia is secondary to uh, parasitic infection. So whenever there is a parasitic worms, nowadays worms are less in the uh, mass population uh, because of water. All of us are taking mineral water only. So more purified water. So you get less helminthiasis. So helminthiasis is the cause of eosinophilia. Now eosinophilia is also in allergic conditions.
Allergy.
Yeah. So like what patient had as allergic cough, sneezing, and all those things. So that is the patient has some allergy, something which is allergy, which is Ig mediated mast cells. The mast cells.
Mast
Whenever
cells.
suppose I am allergic to pollen, and if I go in a garden and if I inhale pollen, my mucosa, nasal mucosa is sensitive to pollen. So that if it pollen touches my nasal mucosa, there is trigger and mast cells go there. So more and more mast cells, more and more there will be running of nose and sneezing and using all these things. And another thing I want to inform you that eosinophilia just don't percentage. See, normally still 6%. You might have of eosinophilia. What we importance is absolute eosinophil count. If absolute eosinophil count more than 700, then only to with whatever treatment, antihistaminics or whatever you want to do. Clinical condition also.
Correct. So if the eosinophils count go beyond 100, then only clinical intervention is needed. Otherwise,
No, not 100. Beyond 700, absolute count.
Absolute count. Because the unit we see here is percentage.
Percentage. So you can ask, you can also calculate the absolute value. So suppose 10,000 is a 1,000 is 100 total count, of which 6 are eosinophils. So absolute 60.
Absolute count is
60. So you can also calculate from total count. In total count is suppose 10,000. Eosinophil is 10. So then you will know what is the amount of eosinophil.
Perfect.
Huh?
So thank you very much.
And eosinophil is also treated. Those who are, they also give hetrazan, which is line of action,
What, sir? Can you repeat again?
Hetrazan. Yes.
Okay.
Treat that.
Thank you very much, sir.
Other thing I want to just tell you this advantage of mineral base that now you don't see much of a. When I started my practice, every alternate stool was positive for roundworm or hookworm or something or like that. Now I don't see a stool having helminths. Thank mineral water and to mineral water vitamin B deficiency also.
Interesting. Ma'am, can you summarize what sir said so we all get a hang of it?
So thank you very much, Dr. Shah. Though his voice was breaking, whatever we could definitely dive into the interpretation of these parameters, and we are very grateful, and to Eileen also. So the context of patient, where the patient is, that also is important for us. OPD level, as Eileen said, if she is in a hospital OPD, she can correlate with the clinician and the pathologist right there. When we have flow of patients one after other, and you're sitting in your own OPD in a private clinic, it is difficult for us to, at that very moment, to finalize or decide what it's. We cannot connect to the clinician or the pathologist at that time. So we can call the patient again and look into it. But what sir said is very rightly, so that you need to see each report, CBC, into deep, like eosinophilia, the two types of eosinophilia, how we are going to segregate and what we are looking at. just cold and cough or an allergy, and what are we going to treat it? As a nutritionist, as I told you in the beginning, we put down our nutrition diagnosis based on the reports. So whether I'm looking at deficiency, whether I'm looking at infection, whether it is bacterial, viral, or whatever infections, or whether I'm looking at just a malnutrition in that patient, and which is giving me this report of low hemoglobin or a differential MCVH or RDW, and how am I going to treat? So for all the audiences, we really sometimes we just open that page and turn to the next page, and because we don't have time, we want to dive into nutrition therapy and nutrition counseling, and sometimes we miss out the right right report, which we need to identify that I need to correct this before I go into the actual medical nutrition therapy. So that's what we gather from Dr. Shah, that it's very important for us to look into it. And where is the patient lying in an ICU or a general ward or an OPD, or you're just seeing a family or friends report and you're finding it these hemoglobin markers or a platelet, or we can medical history will also tell us what it is we are looking at, thalassemia minor, major, or idiopathic, or what thrombocytopenia, because unless and until we ask these questions to the person whom we are treating, we will not come to a conclusion or the nutrition diagnosis that what I am going to counsel or give therapy. So that's what I will gather, that I have gathered from Dr. Shah. And of course, with my so many years of practice, we have been doing it, and I've been always telling my student assessment. Rightly, she said NCB process A, B, C, D, and for each biochemical, clinical, and your diet, three types of nutrition diagnosis you can put, PA statement, and then you put down how you are going to treat that patient. Then I think you will have a better outcome as a nutritionist, and your patients also will feel that no, I'm not sent here pillar to post to anywhere, but at one place I have got my condition taken care into. So that's what very important according to me. Thank
I think
you.
Vanita Chaugule Patil wants to say something. Vanita, over to you, and then we close
Okay.
the session. We will.
Yeah.
Dr. Shah would like to say
Hello,
something.
ma'am. Hello.
Yeah,
Yes,
Vanita.
please, you want to say?
Good evening, ma'am. The session was very nice, ma'am. Just I have one query. I am pure vegetarian, and in my report, blood urea and creatinine are always normal, but blood urea nitrogen is lower side. What may be the cause?
Dr. Shah, would you like to comment on this?
Yeah, don't worry about normal. Low. Low is okay.
Low is
You have
So,
to worry about high.
okay.
If it is low, that means your liver is processing your properly. Your metabolism is good. See, we just, go with the diagnosis companies in pack insert. They say 4 to 25 is normal. We also print the 4 to 25 normal. But there are so many things that are less than 4 also. But they are normal. Especially parameters, creatine. In a newborn, creatine is 0.3.
Yes.
Urea is in some of the newborn patients you are not detected. It is
Exactly.
one. Worry about the BUN.
Okay. Thank you.
Okay, so look,
Thank you,
once
sir.
CBC has so much to interpret. We had inflammation interpretation, we have anemia, nature, normo, micro, then thalassemitic, we have interpretation. We have also looked at the platelet count and thought about thrombocytopenia, which is how it helps us. So I think keep an eye open. The whole CBC means a lot to us, and going ahead, the roadmap also what we've discussed today. So is Nazneen there? Nazneen, would you like to comment?
Yes, I think it has been a beautiful session. When we envisaged the session, we were, uh, really hoping that it can open the Pandora's box, and indeed it has. And thank you, Dr. Pankaj, for really spending so much time on your holiday. And thank you to our dear Eileen for always being around. I think it has been a very, very exciting session, and there have been plenty of comments in the chat box also. And I think people have really loved the session. So Thank you. And Dr. Shah will be touching base with you for many such sessions. And we really appreciate all your patience to decode all of these. I think we really, as dietitians, need to learn more. I think look at things in a different. And Salome, ma'am, for your
Nazneen, Mr. Gandhi would like to say something, and Archana also has raised her hand. So should we allow Mr. Gandhi to say? Uh,
Sure.
People who want to
Yeah,
say
good
something
evening.
because of
Good
lack of
evening,
time,
everybody.
please, participants, you can write in the chat box. We'll convey the questions and get back to you with answers. I think, Mr. Gandhi, you can please unmute and say.
Yeah, I think it was wow session, because even I was listening completely, and there were new revealing facts. Even I was also not knowing, which really came to know, and it was surprise to us that okay, this is how the diagnosis and this is how the interpretation can be done. So wonderful session, and it went off very well. Great, great.
Thank
And
you.
thanks Nazin ma'am and thanks Gita ma'am for suggesting something which is wonderful. And Eileen ma'am, great, maza aa gaya. Thank you.
So, Archana and others who want to say something, please put it on the chat box. Sorry, we can't ask you to because of the time constraints. It's 5:10 already. Dr. Shah is on holiday. He has his more. Dr. Eileen has to leave. Okay, Archana.
Just I want to thank you, ma'am. Yeah, just I want to thank you, ma'am. I am from Vaishali, Ghaziabad, connected with Alpina since long. And Salome, ma'am, really grateful to you all. I could have managed anyhow to join today. It was really a wonderful session. And I appreciate the things that in the South regions, these type of things are happening much and much more. And I will appreciate if we can join from the northern side, from this side also, more of the dietitian. I will try our
Definitely.
best. Yeah.
Thank you. Welcome.
Thank you.
You all are welcome. This is Pan India session, and you are welcome. You can send in your names. Go to our website and enroll yourself also. Thank you.
Sure, ma'am. Sure.
Okay, Nazneen, over to you, and we then say
And
thank you.
Nazmin, you can tell about our YouTube channel and how do they get intimation about our sessions.
Yes, so please go and like our Facebook and our Instagram page. I think the moment you like it, you will start getting all the notifications. We also have all these sessions first DNA live recorded. You can also watch it on our channels, and we will also send participants just in case if you all have missed out on these links, and all the audience who still have questions can directly DM us with the questions. We'll try and revert back with all the answers. And thank you all for being here today. It's been a truly splendid session, and looking forward for many more sessions. Thank you, Dr. Shah. Thank you, Mr. Nitin Gandhi, for you know, being with us through this journey, supporting this entire venture, the entire team of Newsygenic for backing all the science and all the sessions. We appreciate. Thank you, Salome ma'am. Thank you, Eileen. Thank you all,
Thank
audience.
you.
Nazneen ma'am,
Thank you,
For
ma'am.
Nazneen ma'am,
Thank
I just wanted to add one thing. We also have a Nutrivention forum where we are inviting all the dietitians and clinical academicians to write or ask any questions they want to get answered or they want to debate over any topic. On the website, we have added a feature.
Thank you, Pius. Pius is our youngest member in our team, and he's for all the newer innovations that you see on the websites and the social media sites. Thank you, Pius, for driving all of them. Have a great
No
day,
problem.
everyone, and thank you.
Thank you very much. Wishing you all a happy Gudi Padwa and wishing you a very happy Ramzan Eid also, Nazneen. So thank you very much to each one
Thank
of us joining.
you.
Thank you.
Thank you.
See you for
Bye.
the next session.
Love you.